Thank you very much for joining our webinar to mark the release of Right Place, Right Time, Right Team. And first of all, Dr. Chris Kelly and Dr. Rebecca Sutton, who are the study proposers and are going to tell us why the study was proposed. Then Martin Sinclair and Anthony Mikalski, two of the report authors, are going to give us highlights, and there's some time for questions at the end. Yes, over to you.
Rebecca and I are both consultant paediatric anaesthetists at the Royal Manchester Children's Hospital, and it's a comparatively busy centre in that we perform 4,000 to 5,000 emergency anaesthesia procedures per year. And over the course of the last 5 to 10 years, we've been particularly taken by some of the impressive achievements that have been made in adult care for emergency procedures. And it's easy to think of and point to the successes of the emergency laparotomy audit, neck femur audit, AAA audit, and the material differences that they've made for patients up and down the country. And the anxiety often as a pediatric practitioner is that many of these benefits don't necessarily trickle down into paediatric practice as much as they could or should. And so we had a concern that we were being left behind. And so we had many a long conversation to discuss what the best way to target this was, how could we move the needle. And fairly quickly we came to a decision that approaching NCEPOD seemed like a really fruitful thing to do. And I think for those that know NCEPOD will know how unique and useful their approach is and how good they are at tackling these types of problems. And very early on in the conversations Marissa described, I hope she remembers this, that NCEPOD sits in the space between we should be doing and what we are actually doing. And I think this is probably where the central challenge of 21st century medicine really sits, where a lot of the time we know what we should be doing and we may even know how to do it. But the question is, are we doing this consistently, reliably, with low variance? And so the NCEPOD approach to this type of problem seemed absolutely ideal for what we were looking for. And over the course of the last couple of years, really has exceeded each of our expectations, and it's been such an edifying process to work with Marissa and the rest of the team, and to be handheld through this by Heather and the rest of the guys. What has been a big, complicated and interesting process, and we are now very excited about the report and everything that it has. The results that we're going to share with everybody, and the amount of, off the back of the amount of work that's been put in by all these people. So thank you very much, and thanks to NCEPOD.
Well, thanks very much, Chris and Rebecca, for proposing the study, but also thanks to everyone that took part in the study. I think that what you're highlighting there is the importance of all the people that were involved in this study, who came together to try and improve the care of children and young people who are undergoing emergency surgery. And that was really the main aim, was to look at good practice and to look at remedial factors, as we always do in NCEPOD studies, to see what aspects of care we can improve. And there are several aspects of care, and I'm going to come on to that shortly. So just a resume of what the study was about. It was about children and young people between 0 and 18 years of age undergoing an emergency procedure under anaesthetic or sedation, and that could include an emergency procedure in the emergency theatre, in the trauma theatre, one that's put on an elective list to sort of move them from the emergency theatre. Patients that were having procedures in ED where we could find that, and also including interventional radiology. We chose 2 time frames to account for seasonal variation, and those were in February and June 2024, to look at patients who had procedures during those times. We used a sort of multi-layer data source, as we often do with NCEPOD studies. First of all, patient questionnaires. So there were surgical questionnaires sent, just under 700 surgical questionnaires were sent to surgeons that look after patients. 760 anaesthetics questionnaires sent to anaesthetists, and 36 transfer questionnaires. In addition to that, we did case note review, and that involved a multidisciplinary group of clinical people from various walks of life in the clinical community: nursing, ODPs, surgeons, anaesthetists, and other allied health professionals. And that involved case note review of nearly 900 cases. And finally, we used organisational questionnaires, which were sent to hospitals that look after children and young people as an emergency undergoing surgery, to find out what the pathways and organisation and setup of how hospitals work is. We had other sources of information, including a parallel real-time survey to look for delays in care that might be happening on a real-time basis in the sort of emergency theatre setting. So this is a table of all the procedures that were undertaken, and so I'd like to stress that this is not a single condition we're looking at or a single procedure. It's a very heterogeneous group of operations that are happening to, operations or procedures that are happening to children. And this really mirrors the reality of the access problems that we talked about in the introduction, that children face, the complexity of access to theatre for children across the country. We used the NCEPOD urgency, the standard urgency for procedures. And as you can see, there's a spectrum of conditions, including abdominal procedures, urology, trauma, plastic surgery, max, fax, ENT, etc. So the outcomes of this study are applicable across the spectrum of procedures. And I think that's quite important because it's translatable to all children's urgent surgery. So you'd expect, or we would expect, I think, that children undergoing emergency surgery, when they're being transferred, there would be formal pathways and networks in place so that this was a smooth process. However, this is not the case. Networks were not in place, and structured pathways and procedures to transfer patients were also not in place, despite transfers being common. So hospitals said that 13% of hospitals said they were not part of a network for emergency surgery in children and young people, despite most hospitals transferring patients. 93% of hospitals reported that they transfer patients. When we looked at what happened to patients, the pathways were only used in less than 50% of children and young people, so emergency care pathways. And when they weren't used, reviewers felt they should have been in nearly a third. So we'd expect formal pathways, but we recommend that we should provide prompt access to emergency surgical and anaesthetic care by specialists with relevant training and experience in providing care to children and young people. And what that means in practice is that there needs to be shared development of these pathways that go across networks, so that children, when they come in and the decision is made about them having an operation, the route through the system is smooth and speedy. So the second area that we've made a recommendation on is to do with coordination and access to theatre. And what we found was that in hospitals where there was an emergency surgery coordinator, delays in children getting to theatre were reduced. But there's not always someone in this role in hospitals, and theatre booking systems rarely highlighted breaches. So 42% of hospitals said that they had a theatre coordinating manager or clinician, and but only 36% said they had a clinician responsible for assessing capacity in theatre on a daily basis. And reviewers reported that while the majority of patients had their procedures booked without delay, 15% experienced delays due to problems with or in the surgical team. So what we're recommending from this is that one or more emergency surgery coordinators should be in place to ensure that children and young people needing emergency surgery can access theatre. And again, in practice, that means there needs to be someone that takes a responsibility for ensuring that children pass through the process of an emergency procedure in a timely fashion and can escalate care, and there should be escalation processes in place to ensure that they're not delayed longer than necessary and that they identify when they're being delayed. And this has an impact on the next area that we're going to talk about, which is fasting of children for theatre. So fasting was an area that was infrequently recorded in policies for emergency surgery in children. And we identified that patients fasted too long prior to surgery. So when reviewers looked at children's case notes, 17% of children they felt were fasted for too long. And despite pre-procedure preparation for surgery being adequate in most patients, fasting was the most common area for optimization. And I think we all know it's very disabling for children to be fasted for prolonged periods of time. And this affected children that were waiting as a sort of expedited surgery more frequently than for more urgent procedures. So we're recommending that we should prevent children and young people who are waiting for emergency surgery from being fasted for any longer than necessary. And perhaps the theatre coordinators can contribute to this by shifting or advising about when to prolong the length of time if there's a delay that children can have for drinking. And so we should look at policies, or you should look at policies to see whether they can be changed to be more child-friendly and to educate staff, parents, etc., about fasting. And Anthony is going to discuss some of the good care that we noted in the study.
As you all know, NCEPOD puts vignettes into our reports, and both the good and the bad. And these are supposed to be case studies that epitomise something that is happening in healthcare at the moment. And this is a study of good care. It's about a patient who trapped their finger in a door and was seen in the emergency department by the surgical team. They received a rapid assessment, which was great, and an X-ray, and were diagnosed with an underlying fracture. The patient, instead of being kept in hospital, was sent home with pain relief and a plan for readmission in time to be first on the operating list the following morning. They had a night in their own home, and they arrived fasted and ready for anaesthesia. The fracture was reduced and the patient discharged home with full documentation and advice by 12:30, just before lunchtime. So the reviewers reported that this approach, an admission on an urgent hot list rather than using an emergency list, allowed the child to be at home overnight rather than in hospital, with less stress for the family, less stress for the child, and a good management of hospital bed resources. So this sort of good practice, as Martin was saying earlier, is extrapolatable across many different surgical specialties, and we certainly recommend that it's adopted further.
Thanks. So finally, before we go on to discussion, I just want to highlight the report and tools that are available on the NCEPOD website on the Emergency Paediatric Surgery page. So you can get access to the full report, an infographic which helps to explain perhaps to other staff what we found, a recommendation checklist and audit tool which allows you to assess your current services and whether they meet these guidelines, There's a diver diagram and fishbone diagram, which will help identify areas which you can use to look at quality improvement. And there's also a commissioner's guide, which can be used with commissioners to help inform commissioning services for children.